Well, first of all, let me welcome everybody. Let me welcome especially our speakers. They are Dr. Constantina Politis from Athens, very well known and for many years involved now in the European blood safety policies and has been in charge of the Greek blood donation and hemovigilance programs. And Dr. Shah, again, a well-known teacher, if you like, in thalassemia. She's a consultant at the Whittington Hospital in London and involved with the hemoglobinopathy clinics there. I think you all know both of them. And I think we're going to start with Dr. Politis, is that right?
Yes.
Yeah. Dina, I'm handing over to you.
Thank you very much. I'm very privileged to be with all of you again. And although we had about 10 minutes ago an earthquake, a very severe one in the island of Samos, and we felt it here in Athens, I am really ready to try to convey my experience in the issues of blood transfusion, particularly for thalassaemic patients, for the benefit of our patients. So I will start actually with general information on blood transfusion, which is, as we all know, one of the most commonly used means for the therapeutic management of many diseases, including, of course, hemoglobinopathies, and for the transactions of various surgical and other invasive procedures in modern medicine. Everybody knows, and the patients know very well also, that the main targets of transfusion are adequacy of blood, safety, as well as quality. Now, what is the global perspective for issues of blood safety? Well, again, I will marry safety and quality of blood and blood components as a primary focus for everyone involved in transfusion medicine. And I should emphasize in the fact that WHO, the Council of Europe, and the European Union have issued recommendations, resolutions, directives, and various technical guidelines and other regulations in order to ensure safeguarding blood safety. However, contamination of blood components from donors infected with emerging infectious diseases represents a significant threat to the blood supply due mainly to travel, migration, and environmental changes. Now, which are the major pillars safeguarding blood safety? 1, selection of blood donors and testing of donor blood for transfusion transmissible infections. 2, blood grouping and compatibility. 3, blood processing and storage, as well as distribution of blood and blood components. And 4, epidemiological surveillance of adverse reactions and adverse events in donors and recipients. That is hemovigilance for close monitoring throughout the chain from vein to vein. The key components for safe and adequate blood are voluntary non-remunerated regular blood donation, screening for infectious markers, evaluation of procedures, monitoring of procedures, as well as patient blood management, hemovigilance programs. Now, I would like really to put emphasis in capital letters of voluntary non-remunerated regular blood donation, which, as we all know, represents the cornerstone of blood safety because it is ensuring the lowest possible risk of transmitting infections, any type, viral, bacterial, parasitic, other, thus contributing to the protection of human health. According to the 2016 WHO's Global Status Report on blood safety and availability, we know that 74 countries are collecting more than 90% of their blood supply from voluntary blood donors, voluntary non-remunerated blood donors. 72 countries collect more than 50% of their blood supply from family replacement and paid donor. And this is a big and great issue for many countries. Now, here we have a table of the WHO depicting donations given by repeat, regular, voluntary, non-remunerated blood donation. And you can see that there is a great variation if we take into consideration what is the situation in the regions of Africa, in the Americas, Eastern Mediterranean, Europe, Southeast Asia, and Western Pacific. I think the numbers are speaking for themselves. As regards screening for infectious markers, we all know that the current minimum mandatory screening tests contain serological methods and molecular methods. And they are all testing for the Australian antigen for hepatitis B, anti-HIV, anti-HCV, syphilis, and in some situations and in some countries, anti-HTLV1 and 2, and anti-HB core, which are tested on account of better defining their mandate for screening. Now, in the recent 10 years or more, the molecular methods with NAT, nucleic acid screening for HCV RNA, HIV RNA, and HBV DNA still represents the state of the art in many countries for safeguarding safety of blood for these 3 infections, very serious infections. Apart from this mandatory testing infectious markers, the European Directive 2000/98 of the European Union, the so-called Mother Directive, is stressing that depending on the epidemiological situation of each country or in support of transfusion of highly susceptible patients, more stringent blood safety measures should be included or may be included, including blood testing for other infectious markers. And we shall discuss about it later on, particularly as regards the so-called transfusion, transmissible, communicable diseases. We have strategies for suitable donor selection and screening of donor blood, which include permanent or temporary donor deferral, which aims to minimize transmission of infectious agents by transfusion in conditions favorable for communicable diseases outbreaks. Now, the risk of donor exposure to infectious agents and travel history are crucial topics of donor questionnaire and the so-called medical interview of donors, particularly for conditions where there is a possibility of asymptomatic infections or existence of a carrier state. Furthermore, epidemiological surveillance of adverse events in donors and recipients for close monitoring throughout the whole chain from vein to vein, as well as risk-benefit analysis, should be carried out to determine the appropriate measures in order to decrease the risk of emerging infectious diseases in countries without such history and when deferral policies may affect blood supply. A few words about the new and emerging infectious agents, the so-called blood-borne diseases. The spread of insect vectors through travel and trade combined with climate change pose a significant challenge for public health as well as for transfusion medicine in European and other countries. As an example, I shall mention malaria, West Nile virus infection, dengue virus, babesiosis, fever, the chikungunya virus, Chagas disease, which are some of the examples, probably the main examples of such infectious diseases. Now, donor deferral may not be an option in the newly affected areas. And then donation testing is the main tool to reduce the risk of transmission with blood. Although we have pathogen reduction, but only for fresh frozen plasma and platelets, which should be also considered as a great tool. Not, of course, yet for the red cells. Despite all we are doing, all the strategies we are having to safeguard blood safety, there are still threats for safety and quality of blood. And now I'm focusing on something which is not very much understood, even by professionals in blood transfusion. And that has to do with deviations from established procedures and errors, contamination from blood donors infected with old, as we call them, or emerging infectious diseases, and lack of standardization. This is why the guide of the Council of Europe, the ADQM, Guide to the Preparation, Use and Quality Assurance of Blood Components, in accordance with the Directive 2005-62, Article 2 of the European Union, are really stressing upon the good practice guidelines, standards, and specifications for implementing the quality system in the blood establishments. And these have been prepared through an ad hoc cooperation between these two organizations. And this is something really very important, and you can find it published both in the 19th edition of the guide as well as in the 20th, which is in the process for printing. Now, I would like to give a very specific information for our patients and their parents of thalassemia patients for the contribution of hemovigilance in blood safety, a very important chapter in blood safety and quality of blood. But what is hemovigilance? Hemovigilance shall mean, according to the directive, the European Directive 2005-61, hemovigilance shall mean a set of organized surveillance procedures related to serious adverse or unexpected events or reactions in both donors or recipients, and the epidemiological follow-up of infectious disease markers in donors. So hemovigilance can really provide a lot of information if we are collecting the relevant data. Hemovigilance incorporates also an early alert warning system, which is very, very important tool for the various countries that they have established a national hemovigilance system. Why do we have hemovigilance? Why we are preaching for the development and improvement of national hemovigilance systems in the various countries? Because with these procedures, we can prevent the recurrence of adverse events and reactions, or we are aiming in order to prevent the recurrence of adverse events and reactions. Therefore, hemovigilance provides the medical community with useful information on the morbidity from donations and transfusions of blood, and also gives guidance and preventive measures to prevent recurrence of certain accidents or mistakes or errors, human errors, unwanted errors in the transfusion process. In this context, competent authorities for a national hemovigilance system are responsible for warning hospitals and blood transfusion services, both blood establishments and hospital blood banks, about adverse events and reactions that could involve more individuals than a single recipient, including those related to transmission of infectious diseases. For example, recipients of red cells 1, 2 plasma, 3 platelets, and also recipients, those related to blood and other adverse events and reactions related to blood bags, medical devices, solutions, or blood processing procedures. And now, let's concentrate on the thalassaemias that, as you all know, constitute a group of hereditary hemolytic anemias characterized by deficiency that affects the hemoglobin synthesis of one or more of its globin subunits, affecting the A to B globin chain ratio imbalance. Which are the main hallmarks of the disease? The main: ineffective erythropoiesis, chronic hemolytic anemia, and iron overload. You all know very well, especially the patients. And again, the precious data from the WHO on the global data, of course, on thalassaemias. 1.5% of the population, that makes 80 million people, are carriers of beta thalassemia. 60,000 affected children are born annually, while 7% of the population, and that corresponds to 266 million, are carriers of beta thalassemia, sickle cell, and hemoglobin E beta thalassemia, double heterozygosity. TIF stresses that 100,000 patients with thalassemia syndromes are recorded to be under treatment. However, these data are grossly underestimated since few countries have national registries or epidemiological data. And this is something which is of great concern for TIF as well. And this is a map of TIF for the clinical management of thalassemia. And now the clinical spectrum, a few words. We are having, as we all know, two classes: the transfusion-dependent thalassemia patients and the non-transfusion-dependent thalassemia patients. In patients with transfusion-dependent thalassemia, the factor responsible for the disease process is secondary iron overload from regular transfusion therapy. And that can lead, as we all know, to organ damage and failure, especially the heart, liver, and endocrine glands, including growth retardation, delayed puberty, hypogonadism, hypothyroidism, impaired glucose tolerance, and adrenal insufficiency, many morbidities, many. Other complications of regular transfusion, very, very important: alloimmunization and transfusion-transmitted infections. Of course, the cornerstone of treatment for thalassemia is blood transfusion. And the recommended therapy in thalassemia major is regular transfusion of safe blood of good quality and monitoring of related complications. So safeguarding blood safety for thalassemia is a very primary focus. And efficacy and quality, including adequacy, should also be ensured. Now, fulfillment of these objectives vary considerably across the globe and between countries and across regions, mainly on account of social, economic, and epidemiological conditions, health infrastructures, and their health priorities. We all know that. Now, effective transfusion therapy in thalassemia. Of course, I know that Dr. Shah is going to talk about it, but I would just like to stress a few points: that effective transfusion therapy allows normal physical activity, improves growth and pubertal development, prevents bone marrow malformation, prevents organomegaly, increases survival. and very importantly, improves quality of life for patients and their families. The blood requirements in thalassemia major depend on the molecular basis of thalassemia, the age of the patient, and his or her clinical conditions, splenectomy, alloimmunization, other. And the transfusion regime, as you see, it is 1 to 2 units of red cell concentrates every 2 to 4 weeks. For moderate transfusion regime, that means the achievement of a pre-transfusion hemoglobin level of 9.5 to 10 grams per dl, which allows effective prevention of iron loading. And it also permits spontaneous pubertal development in contrast with hypertransfusion regimens, once favored. This is a nice picture from many patients taking blood, and they are feeling very happy with their pupils. Now, a few words about the technical standards for quality and safety of blood. They are all mentioned in the directives of European Union, and as well as not only the technical standards, of course, for blood donor selection and testing, but also the hemovigilance programs. And traceability procedures are also mentioned in the directives of European Union. And the pre-transfusion and transfusion measures recommended by the EDQM Council of Europe in the Guide to the Preparation, Use and Quality Assurance of Blood Components can really be guiding clinical as well as colleagues working for thalassemia in general, and as well as blood banks preparing blood for this group of patients. More particularly, I would like to mention that the specific measures for transfusion are focusing into what is called to provide the right blood at the right time for the right patient. And other procedures look at depletion, washing of red cells, accurate cross-matching, and antigen and antibody screening for an extended matching policy. These are specific procedures which are in the everyday's life for the blood banks preparing blood for thalassemia patients. However, despite all the efforts the blood bankers are putting really in order to provide the safest and best quality blood in the chronically transfused patients, chronic transfusion itself exposes the patient to various risks: alloimmunization, disease transmission, and hemosiderosis. Of course, the level of risk depends on the time of onset of transfusion, the quality of the transfused product, the appropriateness of performance, very, very important, the appropriateness of performance, and of course, the number of the units transfused. So in thalassaemic syndromes, including sickle Thal, requiring chronic transfusion, the risk is higher than in other hematological and oncological diseases. This is something we know very well, all of us who have been working all their life for thalassemia patients. And now, before I close my presentation, I would like to give you the example of Greece, giving you some information on the national blood supply. Greece is an endemic country for thalassemia, and 20% of the national blood supply goes for thalassaemic syndromes. As regards now the constant and continuous work and surveillance we are doing in order to know and follow up the seroprevalence of transfusion-transmitted infections in patients with thalassemia and sickle cell disease thalassemia patients, I have a table here to show you the prevalence of the so-called old infections and some of the new emerging infectious diseases, such as West Nile virus and anti-hepatitis E. Now, who are in Greece, as in other countries, we are applying strategies to eliminate alloimmunization. Depending on the, we have alternative phenotypic matching standard strategies. The standard is to test for ABO, rhesus, D, and KEL. The extended strategy one, also, I mean, the first one, when I say rhesus, I mean just D antigen. Here we are having C and D. In the extended strategy 2, we are adding to the above specific antigens, and in the extended strategy 3, we are having Duffy, Kidd, MNS, Lewis, Lutheran, and other antigenic systems. So prophylactic matching in the case of history of alloimmunization or in the presence of hemolysis is something very important. And in this respect, I would like to conclude saying that one has to individualize really the appropriate strategy for each patient, and this is very important. We are having several studies in the last 20 years in order to follow up the evolution of alloimmunization as well as autoimmunization in our thalassaemic patients. I do not have much time in order to discuss about all these findings. We are doing very well, especially after 2010, when we decided that the group of thalassemia patients would be contained as a specific group for hemovigilance and surveillance for alloimmunization and any adverse event or reaction. So now I will finish saying that we have new advances which are promising a lot of improvement for safety and quality of blood for thalassemia. And we are hoping that soon we will have pathogen inactivating red blood cells. Many blood establishments and many hospital blood banks have adopted molecular immunohematology advances as well as barcoding and computerization. And now, of course, a few things, because I know that in the patient's mind, as in all of us, in all of our minds, it's the COVID-19 infection. SARS-CoV-2 is a respiratory tract virus with highly increased transmissibility and morbidity, as we all know very well, everywhere in the world, particularly, of course, hitting vulnerable patient groups. Transmission by blood of the coronavirus, the new coronavirus, is only theoretical. I'm very glad to tell you that in the literature, including some of a recent study we performed in Greece, we have shown, we have brought some evidence supporting lack of transmission of this nasty virus by blood components. And in press, some study we have performed taking samples from both thalassaemic patients and blood donors. In the period February to July 2020, we have tested 997 thalassaemic patients for antibodies against the coronavirus 2, and the prevalence is really only 0.4%. 8,100 blood donors were also tested for the same antibodies, and the prevalence was only 0.5%. In conclusion, blood is safer than ever in the developed world, but this is not the case in many regions, still in many regions around the world. And this is why, as Panos Englesos, the president of TIF, our good, wonderful, our friend Panos, whom we all adore, and thank him for what he has done all his life and what he's still doing, TIF is particularly focusing in the promotions of initiatives towards ensuring the safety and adequacy of blood, which is a key component of the lifelong management of patients with transfusion-dependent thalassemia. Which are the conclusions? Risks and threats will always continue to exist, despite the fact, what I said before, that today, nowadays, the blood is safer than ever. Risks and threats will always continue to exist. And evaluations of the cost effectiveness of antigen matching strategies should take into account the effectiveness of the general clinical management of thalassemia and sickle cell disease. So this is something that we have really to take into consideration as clinicians for thalassemia. On the other hand, a multidisciplinary clinical approach and close monitoring of alloimmunization and delayed hemolytic transfusion reaction is also essential. Future advances in laboratory testing, e.g. individualized genotype, matching of red blood cell transfusion, as well as HLA antibodies investigation in patients prone to developing red cell antibodies are also suggested. And finally, pathogen inactivation of red cells, as I mentioned before, is expected to improve significantly blood safety. In general, I always thought, and I was also preaching in the ISBT meetings and hematology meetings and thalassemia meetings, that hemoglobinopathies is a global issue. Thank you for your attention, and I shall be here and ready to answer your questions. Thank you very much for your attention.
Dr. Politis, Dina, thank you very much indeed. You have in fact demonstrated the complexity of and the number of things that the blood bank has to think about so that patients receive blood that is safe and effective. So it's a long process, it's a difficult process, and thank you for demonstrating it. I think we should leave questions after
Yes.
the next presentation.
Yes.
So that you can both be approached.
Thank you very much, Mike.
Dr. Dr Shah, your turn. And it's more thalassemia specific, I think, isn't it?
Yes, it will be, yes. Right, so I'm having a bit of a problem again with sharing my screen. Let's get this up. Hopefully this will work. There we go.
Here you go.
Whoops. Sorry. Okay, so thank you very much for asking me to talk about blood transfusion in thalassemia. And this is really going to be focused very much on what I feel is very important for patients to know and for patients to feel confident about with regards to their blood transfusions. So conventional management for thalassemia, the mainstay, as Dr. Politis has said, is transfusion and iron chelation. And we're going to focus on blood transfusion and how we can make sure that this is optimal for patients. In patients who don't receive blood transfusions, you get this sort of a situation with a child with very stunted growth, a very large liver and a very large spleen. And one of the things that we aim to do with blood transfusions is to avoid this developing in our patient population. And in fact, the very first description of thalassemia by Cooley's in 1927, you can see here on this X-ray the hair-on end appearance of the swelling of the bone that happens as part of inadequate blood transfusion. The skull isn't the only bone to swell. What you can get is very significant expansion of the bone marrow. So here you can see a part of a long bone in a patient, and you can see here very, very swollen bone marrow full of red blood cell manufacturing cells. And this is not normal. This part of the bone is supposed to be full of fat, not full of blood. In low resource countries, because of shortages of blood and not having a safe blood supply, you end up with children and young adults who still look very thalassemic. And what you can see with both of these young girls here who are in their late teens is you can see that they have classical thalassemia faces. And that's because of inadequate transfusion. What we're aiming for our patients is this: a thalassemia major boy who's able to play football, run around, looks completely normal, and has an extremely good quality of life. And that's what the aim should be for all patients. So by giving blood transfusion, we aim to correct the anemia. We aim to ensure that there is normal growth, reduce the risk of infections, and prevent other complications of anemia. But also we're going to be trying to suppress the bone marrow so that the bone marrow is no longer producing poor quality red blood cells. One of the most difficult things around transfusion is making the decision about when the right time to start transfusion is. For a thalassemia major child, it's usually fairly straightforward. And we generally tend to say, and the TIF guidelines say, that you should start blood transfusion when there is failure to thrive, when the little child is failing to grow and develop, or they are developing enlarged livers or spleens. Once you start transfusion, it's very important to continue blood transfusion, because otherwise you end up with these cycles of having a good hemoglobin followed by a low hemoglobin, and that can then cause problems. And I'll go on to talk about some of those problems further on in the talk. The decision about transfusing somebody with thalassemia intermedia is much, much harder. We still use the failure to thrive, grow, and develop. And that's an important one, particularly in NTDT or thalassemia intermedia patients when they go in towards puberty. We may see that they fail to grow at that point and they fail to move into puberty, at which point a relatively short period of blood transfusions could get them to grow and to move into puberty. So in thalassemia intermedia, failure to thrive, grow, and develop. Also in thalassemia intermedia, the development of bone deformity, so extramedullary hematopoiesis, severe osteoporosis causing bone fractures. In some of our patients, we transfuse them if they're prothrombotic, if they've had a lot of thrombotic events, and they are also post-splenectomy. And any patient who's got pulmonary hypertension or venous ulcers should be considered for a transfusion program. This is a new baby with thalassemia major, and this is the benefit of plotting the growth in a patient. So here you've got a baby who's now 6 months old, and what you can see is that this baby's growing very well at the beginning, but then starts to fail to thrive. And what you can see here is that they go from being on the 50th centile down to the 2nd centile. And we then start blood transfusions because we've got evidence of failure to thrive. In this young baby's case, the father actually needed to see this graph and to see the fact that the growth had really fallen off before he agreed to blood transfusion. This is a young girl with thalassemia intermedia, and what you can see here is that she is here 13 years old, and she's very, very low on the centile chart. She's just not moving into puberty. She's very small. In fact, her mother and her father are both very short. But what happens here is that we start blood transfusions, and you can see that there is a dramatic improvement in her height velocity. Her BMI improves, and she actually moves through puberty very, very nicely by starting her off on regular blood transfusions. She is now, I'm pleased to say, taller than her mum. So what blood should we give? Well, definitely ABO, and it should be matched for C, D, and E antigens, both the small and the big. and should also be matched for KEL. Now, this is not available in all the countries in the world. And in many countries, the matching is just for ABO and RHD. And we should aim, if at all possible, and the resources are there, to ensure that we are matching as closely as possible because of the risk of alloimmunization, as Professor Politis very nicely explained. Blood should be filtered. In good resource countries, blood is pre-filtered very soon after the donation, and it's not done through bedside filters any longer. And this reduces the risk of transfusion reactions. Where possible, we should be aiming to use blood which is less than 7 days old, and it should be compatible for CMV. And it is definitely the choice to give packed red blood cells. Whole blood causes a lot more transfusion reactions, and we need to avoid that. Initial management, once you know that you've got a thalassemia patient, is to start hepatitis B immunization. And we start transfusions when the hemoglobin is less than 7 on 2 occasions, or there is evidence of failure to thrive. Or we may start it when the hemoglobin's above 7, if the patient is developing facial deformities or there are other features. There are a number of different types of transfusion regimes. There are hypertransfusion, moderate transfusion, and low transfusion regimes. And what we aim to do, if you've got a good blood supply, which is secure, is to try and maintain people on a high transfusion regime, which means keeping the pre-transfusion hemoglobin above 9.5. Moderate transfusion regimes are where the blood supply is less well developed and less secure, in which case keeping the hemoglobin close to 90 or 9 grams per liter is an option. And low transfusion regimes are unfortunately the type of regimes that happen in many low resource countries with not very good blood supply. And in that situation, the hemoglobin is being kept quite often around 7 or 8 grams per liter, and these are low intensity transfusion regimes. The decision to transfuse should be made by an experienced healthcare professional, a doctor or a nurse. It should be given in an appropriate environment. And it's very important to monitor the amount of blood patients are receiving on an annual basis. And for quality of life, we should be aiming for out-of-hours blood transfusion so that as the patients go to school, go to university, and then start to work, their regular blood transfusions, which are the mainstay of their therapy, do not impact on their ability to both study and work. Now, there are some questions that can often get asked, and I'm going to answer these as a kind of a question type of a format. What if my hemoglobin is kept low? Well, if your hemoglobin is kept low, your spleen and your liver can get bigger. And once the spleen is enlarged, it can start to destroy the transfused blood cells. And this condition is called hypersplenism. Once you have hypersplenism, you enter into a vicious circle where you need more blood to maintain a good hemoglobin. And that causes more iron overload. And the spleen becomes bigger, and you run into this cycle where you often end up needing a splenectomy because the patient has a low white cell count, they have a low platelet count, and the spleen is destroying other components of the blood, not just the red blood cells. Also, if the hemoglobin is kept low, you can develop extramedullary hematopoiesis, which is expansion of the bone marrow, and you can get worsening of the osteoporosis. This is a young woman with very bad extramedullary hematopoiesis, and what you can see here is that the maxillary part of her bones have really expanded very badly. This is one of my patients who has extramedullary hematopoiesis. She is a non-transfusion dependent thalassemia patient. And we did this MRI scan because she was complaining of a persistent cough. And what you can see here is that the bone has expanded and it's pressing on the nerve and the lung and on the bronchi. And that is then causing this persistent cough. And her spleen is almost as big as her liver. So this is what extramedullary hematopoiesis looks like in its most severe form. She is now on regular transfusions. And in fact, starting blood transfusions meant that her cough disappeared within about 3 to 4 weeks of her starting to have regular blood transfusions. This is one of my thalassemia major patients, and this is another thing that's very important about the risk. This gentleman was very busy at work. He let his hemoglobin go down to 80 for about 2 to 3 months, and he was delaying transfusions because he was so busy. And what you can see here is that the bone in his spine has begun to expand, and he's now got this very big tumor of extramedullary hematopoiesis. And that was from a relatively short period of under transfusion. So the aim is to avoid getting extramedullary hematopoiesis in the first place. It's very important to keep a good hemoglobin. And often extramedullary hematopoiesis, if you have it, does not need treatment, particularly if the swelling is not big and if it's not pressing on anything vital. But it is important to get the hemoglobin into a good range. If there is an issue and you do need treatment because the mass is too big, it's pressing on an organ or it's causing a problem, then what we recommend is hypertransfusing and keeping the hemoglobin above 100 or above 10, to consider radiotherapy to shrink it down a little bit. And we also start patients on hydroxyurea so that there is less ineffective erythropoiesis, and that is actually pretty successful at converting the extramedullary mass into fatty marrow, which is less of a problem. I was talking about enlargement of the spleen, and this is one of the really important issues around hypersplenism and why it's important to avoid splenectomy if at all possible. So extramedullary hematopoiesis leading to hypersplenism will lead to splenectomy. If you can avoid the extramedullary hematopoiesis as a consequence of the anemia and avoid splenectomy, you will do better. This is data from the optimal care study, and the important take home from this is that your risk of developing pulmonary hypertension, thrombosis, gallstone problems, leg ulcers, and osteoporosis go up if you've got or have had a splenectomy. So avoidance and prevention is without a doubt better than cure. And certainly in the beta thalassemia patients, we should aim to hypertransfuse and avoid splenectomy. So optimal treatment basically means that we should be aiming to give our patients a nearly normal quality of life, which disturbs their life to the most minimal amount possible. We should aim to avoid the development of both fatal and non-fatal complications, and that means avoiding the development of extramedullary hematopoiesis, avoiding the development of hypersplenism, and therefore preventing a lot of these complications. Our oldest patients are now in their late 60s, and we should be aiming to ensure that our patients have a really good life expectancy. Today, our patients in good resource environments, they run marathons, they play football, they become whatever they want to be. We have doctors, lawyers, we've got criminals as well. But we should be aiming to encourage and support our patients to become whatever they do want to be. They should be allowed to travel the world, have children, and retire and eventually die of old age. We do not want our thalassemia patients to have thalassemia rule their lives. I just want to say thank you to my team. I am a small part of a very, very good team, and I wouldn't be able to do a lot of the work that I do without the very important people that actually help me do that. Thank you very much.
Dr. Dr Shah, thank you very much indeed again. It's time to have some questions from the patients. Gadia is our education specialist to support TIF in its educational programs. And Gadia, will you be voicing the questions, please?
Yes. Okay. Thank you, Dr. Shah and Professor Politis. The first question This question is for Dr. Shah. The first question, IV desferal with blood transfusion in thalassemia as additional chelation. How helpful is that?
Okay, a very important question. What I can tell you is that we don't recommend blood and desferal being given at the same time or even afterwards intravenously. The main reason being that in the old days, people used to get 2 grams of desferal with each bag of blood or 3 grams of desferal for their blood transfusion. Desferal works best if you give a low dose over a long period of time. So giving desferal over a short period of time doesn't benefit. You basically pass out a lot of desferal in the urine, which is not bound to iron. The second problem with doing it this way is that you end up damaging the blood vessels. And in thalassemia patients, we need you to protect your blood vessels as much as possible because you need those blood vessels for the whole of your life for your blood transfusion. Damaging them by giving you high dose desferal over 3 or 4 hours is not going to help you in the long term. So if you can, you should do desferal subcutaneously with your blood transfusion, absolutely fine. You can do your desferal intravenously through a PICC line or a portacath, absolutely fine. But try not to do your desferal high dose, short period of time intravenously.
Okay, thank you, Dr. Shah. The next question is for Professor Politis. In many cities in India, these safe blood transfusion facilities are not available. What should we as patients always pay attention to?
Well, I think the main issue is really to try to cooperate with a very good association of voluntary blood donors. I know that in India, you have excellent networks of voluntary non-remunerated blood donations. And in this aspect, and following an old example of Greece in this issue, the Pan-Hellenic Thalassaemia Patients Association was always cooperating with voluntary blood donors associations in order to motivate the public for giving blood regularly. On the other hand, I think that the Association of Thalassaemia Patients in India must really have an open dialogue and continuous dialogue with the country's government in order to secure and make sure that there is a commitment from the government of India that gradually a strategy for developing voluntary non-remunerated blood donation will be the best way in order to have adequacy of blood and safety of blood. I know this is really difficult. And I know that in many regions of India, more than 50% of the blood donors come from the class of family or replacement blood donors. This may be a solution for the time being, but if you follow the guidance of the Red Cross International, you will see how in many countries it was possible that you can follow strategies for the convertment of replacement family donors to regular non-remunerated donors who are providing blood for the unknown individual patient in need of a transfusion.
Okay, thank you. The next question is from Dr. No. It's for Professor Politis. Thanks for an excellent talk. Would you be so kind to explain what OptiMatch means regarding blood safety? Is this HLA antibody testing?
Not regularly, only in certain situations, particularly when some patients are waiting for a transplantation. And in this situation, yes, we need the help and the cooperation of a specialized immunology laboratory. On the other hand, I wouldn't really put that much emphasis on the HLA testing. Blood safety is a very complex issue. And as Dr. Angastigniotis pointed out following my talk, we have so much to do. We have so many measures to take. And these are all very well defined. And there is an effort now from the WHO, the Council of Europe, the American Association of Blood Banks, the International Society of Blood Transfusion, and many other scientific international organizations to try to harmonize our practices in this issue so that we are all doing the same thing. And through hemovigilance networks, we gather information from all over the world in order to try to develop the so-called benchmarking, which is a procedure to gather data from various countries and try to compare each other in order to adopt the best practices and learn from each other.
Thank you. Next question is for Dr. Shah. For thalassemia major, as often as to maintain a pre-transfusion hemoglobin no less than 9.5.
Yes, so we would definitely, that is for in a good resource country where there's blood, it's safe. We would definitely say that you should aim to keep your hemoglobin no less than 9.5.
Okay. The next question again is for Dr. Shah. A non-transfusion dependent thalassemia patient maintaining hemoglobin of 9.5 to 10 grams on hydroxyurea dose of 500 milligrams per day. Patient weight is around 52 kilograms. Had 2 to 3 thrombotic events. Treatment was given. Presently now on ecosprin, 75 milligrams, and nicomalone, 2 milligrams per day. Ferritin around 550. MRI is no iron overload in heart and liver. So the question is, should the patient maintain, keep taking hydroxyurea or regular blood transfusion?
So a really important question from Jatin, and I think one of the really important things is around making sure that your clinical medical lead, your doctor, is overseeing your care. So, you know, with a hemoglobin of 95 on hydroxyurea, there's no reason to not carry on with hydroxyurea, and to certainly if you live and work in India, then it would make complete sense to not be transfused in this situation and to continue with hydroxycarbamide. Yes, you've had thrombotic events, and you know whether those thrombotic events are related to your post-splenectomy status or not is a very important thing. You know, in the UK, we would have a very long discussion with the patients about this issue and about continuing with transfusions or continuing with hydroxyurea. I have to say that I would bow to patient preference, because I know that in the UK, my patient will get good transfusion. They'll be able to take iron chelation. I am not anti-blood transfusion in that situation, because I know my resources are there to do that. But that isn't the case globally. So you have to look at the individual. I can talk about the perfect world, but the world is not perfect. Yes?
Yeah. Thank you. The next question, again for Dr. Shah, for TI, we have to prevent them from these complications. So we have to start transfusions earlier before they have all these problems.
Again, really important now. Dr. Wonky, Prof Porter, you know, my mentors throughout my career have said all the time, whatever you do for a thalassemia intermediate patient, if you transfuse them, if you don't transfuse them, whatever decision you make, it will be the wrong decision. I think NTDT thalassemia intermediate patients are the most difficult, complex patients to manage. And I would say that every single decision you make for a thalassemia intermediate patient, you need to look at risk and benefit, and the decision has to be made with the patient and what they feel that they can do, because they don't need to stay on blood transfusions to stay alive, but you may kill them earlier if they can't take iron chelation. So the decision has to be focused around the patient and what is the right intervention for that patient. You cannot do one thing for everybody.
What's your opinion on thalidomide in thalassemia major?
Oh, thalidomide. I'm sorry. I have lots of issues with thalidomide. It is used a lot in India and in other countries as well now. But my personal view is that thalidomide is a very serious drug with very serious complications, including thrombotic risk. I think that the use of thalidomide should be overseen by a placebo-controlled randomized trial done on an international level. And once we have good quality evidence for the use of thalidomide, then it should be used, but it should not be used outside of a clinical trial because we actually don't have enough robust scientific evidence.
Okay, and to maintain hemoglobin more than 9, blood to be transfused very frequently, thus iron will be overloaded. It is also dangerous for the organs. What's your suggestion?
Take your iron chelation. It's really important to have good hemoglobin so that you can do all the things you want to do in your life. But obviously the blood is going to give you iron overload. And if you don't take your iron chelation at the right dose, then yes, you will get iron overload. It is a balance. So if you want to have a good quality of life, you have to take your blood properly, do it correctly, keep your hemoglobin good, but also make sure you take your iron chelation. There is nothing in life comes without a price. And the price for having a good hemoglobin is the fact that you need to take your iron chelation at the right dose on a daily basis.
Okay. For both, Ahmed is saying that thank you to our doctors for important information. Whittington Hospital was my first hospital, which I started my new life with Dr. Wong and Dr. Farooq Shah. My question is, what is the very last dated blood for transfusion?
So I assume Ahmed is asking about how old would you give blood? My choice is less than 7 days old, but I have patients who have lots of antibodies. And if I need to transfuse them and I cannot get blood that is less than 7 days old, then I will transfuse them with whatever blood I have available. And that means that if the blood is 28 days old, I will use that because my patient needs the blood to stay alive. So it is based on the antibodies and how easy or difficult it is to get blood for an individual patient. We have patients where we give 28-day-old blood because there's no blood available for them. And for the majority, we will give blood that is less than 7 days old.
I would like to contribute to this discussion about this issue of freshness of blood, the necessity of this. In my country, we are trying to provide blood as fresh as 15 days old, and if possible, 7 days old. However, in the context of many discussions and good research in the field of blood transfusion medicine, there are a lot of questions about the validity of providing the so-called fresh blood. There are many studies by Professor Olivier Garot and his team and other people who have been examining the quality of blood of, let's say, 28 days old, which is equally good as the one 7 or 15 days. So this is an open, actually, there is no clear answer from our side. When I say our, I mean the group of people dedicated to transfusion medicine. And still, I wouldn't worry about the freshness of blood, particularly nowadays. And I take the opportunity, since I have the floor now for a moment, to try to encourage everyone that during this tremendous, terrible, nasty pandemic, we are not have threats for the blood safety, but we have a great threat for blood adequacy. Mm-hmm. Because people are afraid to go out of their home and go to give blood. This is why in Greece, since mid-March, about 10 days after the first COVID infection was diagnosed in Greece, we really took action, and we had developed a campaign, a pan-Hellenic campaign, which has been really very effective and very successful, that we all can, and we have managed in cooperation with TV and radio channels, with municipalities, with church, with all voluntary blood donation, donors associations, with everyone, really to organize out of hospital blood banks and out of blood establishments, installations to organize blood sessions. So the blood drives in this way, and with strategies of taking very, very well-defined and very strict measures following the instructions of the ECDC, CDC, and WHO. I think we have been really managed not to have difficulties, great difficulties, but now that we have the second wave of the pandemic, I have a heart beating if we shall manage to do it. And I would like to share with other people here in this forum what is their experience right now at this moment. Thank you.
Thank you. The next question, what is the role of hydroxyurea for transfusion-dependent patients?
None.
Okay. And vaccination in thalassemics for hepatitis B?
Everyone should. It's a standard of care that they should be immunized against hepatitis B.
Okay. And the last question, can diabetic be reversed in non-transfusion dependent thalassemia patients, type 2 diabetes? Pancreas has iron overload, heart, liver is clear in MRI, ferritin is 550. What dose of DFX can be used to remove iron in pancreas?
You can't. Type 2 diabetes is because of your genetic predisposition, and it's to do with weight and the type of food you eat. It is not. It is reversible, but it is not reversible by iron chelation. If you've got iron in the pancreas, I look after a lot of thalassemia patients. Many of them are diabetic. I have never seen diabetes reverse with iron chelation therapy. So if you are type 2 diabetic, lose weight, take regular exercise, reduce your carbohydrates, do all the things that type 2 diabetics should do, I would not be living in a land of wishful thinking that, you know, it will reverse with iron chelation. It won't.
Okay, thank you. That was the last question.
Yeah, so it's really up to me to thank everybody. This was a very interesting session, and the patient response bears witness to that. So we've thanked both the speakers because, as I said, you have stimulated thought and discussion. Thank you very much indeed, and we can now close the session.
Thank you very much indeed.
Thank you.
Thank you. Bye-bye. And all the best. Keep safe.
Thank you.
You too.